Okay, chest pain. So every year there is 1,150,000 presentations of chest pain to the emergency department in the UK out of a total of 23 million. So that comes to about 5% of all presentations to the ED is a patient with chest pain. So it's a useful thing to get to know. So if we follow the breadcrumb trail at the top, we'll begin with a differential list. Now I like to think of getting your map out because you're looking for the cause of chest pain. It just so happens that the most common and important causes of chest pain begin with M, A, or P. So your M is a massive P, or MSK problems like costochondritis. A is abdoreferral pain like GORD or peptic ulcer disease. ACS and aortic dissections. And there's a few P's. Pneumonia, which I abbreviate as CHAP because that's both community and hospital acquired pneumonia. Pericarditis, particularly when it becomes constrictive pericarditis, a minor pulmonary embolism, including recurrent emboli, mini emboli, that cause ramp symptoms and a ramp loss, and then PNX, which stands for pneumothorax. So, if we begin with the history, massive P versus an MSK, what kind of things will the patient be telling you that points toward a P? Well, first of all, you have an embolism in the pulmonary vasculature, so breathing will be affected. Shortness of breath, and the result is a sharp pleuritic chest pain. Now, the quality of pleuritic chest pain, when the pleura is inflamed or irritated, patient inhales, intrathoracic volume increases, the pleura gets stretched, and the area of inflammation is very localized. So the patient will say that when they breathe in, the pain is worse, and the pain is a stabbing, very localized quality. That's what pleuritic chest pain means. And rarely hemoptysis and syncope in the late stages. Now, the textbooks always like to put hemoptysis, pleuritic chest pain, shortness of breath, and the differential is P. Hemoptysis is very rare. I think it's about 2 to 3% of all PE presentations, but the literature likes to mention it, so it's probably on exams a lot. Now, MSK is often exercise-induced chest pain. It's replicated with touch. So unlike pleuritic chest pain, which is replicated on inhalation, if you touch the area of cartilage or bone or muscle that is inflamed and irritated, say costochondritis parasternally, you'll have a replication of that pain. It's non-pleuritic, so it is not worsened by inhalation. So if we move to the A's now, abdo, so GORD and peptic ulcer disease. So these kinds of pains are a bit different and quite characteristic. They're worse when the patient's lying down and when they take warm meals or have drinks. The quality is a burning sensation which is called pyrosis in the medical nomenclature, and they have a history of smoking, alcohol, fatty foods into middle age. ACS, the quality is different, so it's not a burning sensation, it's crushing retrosternal pain with a referral to the C3 to 5 dermatomes. They will look grey, they'll have a pallor, nausea and vomiting may result, and then torrential sweats, or diaphoresis as it's called. They'll have a similar history. In aortic dissection, it's a tearing pain, so it begins behind the sternum and then is said to march to the back because the aorta is retroperitoneal. So if it's dissecting, you're getting blood into that cavity. So initially it's referred pain and then it localizes posteriorly. So interscapular, between the wings of the scapula. The patient will present dyspneic, and then as the bleeding continues and they start to exsanguinate, hypotensive, progressing to shock. And they'll have a history of Ehlers-Danlos syndrome or Marfan's, any connective tissue disorder that means that the aorta is more likely to dissect. So now the P's. So if we begin with pneumonia, they'll have a productive or dry cough and shortness of breath. They'll have fevers, rigors, and myalgia, and at-risk populations are more likely to be affected. So for your hospital-acquired pneumonia, it's patients that have been there for a while, usually greater than 2 days, ventilator coma patients. And for community-acquired pneumonia, it's usually the older people in residential homes and things. That's your classic history of pneumonia. Pericarditis, particularly if it becomes constrictive and is bordering on tamponade, you have what's called Beck's triad, which is muffled heart sound. So if you have inflammation and thickening of the pericardium and fluid building up, then when you try to listen to the love dubs, they'll be muffled. Because there is a constriction on the actual heart muscle itself, with the pericardium, the consequence is that preload is decreased and cardiac output is decreased. So there's a raised JVP and hypotension. We've already mentioned PE. And then your pneumothorax is quite straightforward. So you get acute pleuritic chest pain, that localized stabbing pain that's worse when you breathe in. They'll be short of breath because they have a collapsed lung. And then if it's primary spontaneous, it's a history of youth, or trauma if it's a tension or a secondary. So let's see what you're looking for on an examination for these different differentials. So for massive PE, the patient will be tachycardic, short of breath with an elevated JVP and sometimes a fever. So hypercoagulable states as part of Virchow's triad will cause clotting to increase, obviously because it's hypercoagulable. Fevers and infections are common causes of hypercoagulability. MSK, so reproducible pain, as we said. If you touch it, it's worse. Abdo Gord on the exam, there's no real specific findings. It's mostly history and investigations. ACS, often normal. But if the heart is particularly failing, you might get acute cardiogenic pulmonary edema, and that will present as bibasal rales or crackles. And if the heart is damaged, you might have abnormal heart sounds. For aortic dissection, you can have unequal pulses if the dissection is causing hypoperfusion to one of your upper limbs. So you feel the radials and one might feel different to the other. And it might progress acutely into aortic regurgitation as the blood is thrown back with the turbulent flow into the heart. And focal neurological signs later on as the ischemia is quite profound. So for pneumonia, community and hospital acquired, there'll be decreased breath sounds and consolidation. And the bronchial breath sounds is when you inhale and there's a pause and exhale. Because vesicular breath sounds, the normal one should be in and out, in and out. But the pause is bronchial, and that suggests inflammation, that suggests consolidation. Now pericarditis, that's your Beck's triad that we've already discussed. And pneumothorax, where the collapse is, there'll be absent breath sounds because the lung has collapsed away from there, and there'll be increased resonance when you percuss. In the late stages, you can have tracheal deviation rarely and JVP raised as you have intrathoracic pressure increase, which decreases preload. So, for the investigations and management of these conditions, let's go through them in overview. So for a massive PE, you need to do an ECG, chest X-ray, and then a D-dimer CTPA algorithm based on what we'll discuss. So ECG will be sinus tachy, non-specific usually. There may be some right-sided heart strain as the heart tries to push against the clot in the pulmonary system. Chest X-ray might show mini infarcts depending on where the ischemia is based on the embolism. Oh my god, that's my stomach. Now, when you're trying to follow the algorithm for a Wells score, you're going to do a simplified Wells score. This is what it is, and this is an assessment of the probability of a pulmonary embolism. So this informs your management, okay? A score of 4 or lower indicates a pulmonary embolism is unlikely, okay? So they have to score greater than 4, okay? So if the patient is considered to be at a high risk, so greater than 4 on Wells, and is D-dimer positive, so risk is high and D-dimer positive, you're going to treat the patient, and we'll discuss how in a minute. If Wells is high and D-dimer is negative, you're going to ultrasound the lower limb and perform a CT pulmonary angiogram. If the risk is low, if Wells is low but the D-dimer is positive, same again. And if the risk is low and the D-dimer is negative, you're going to do a differential diagnosis. You're going to go back to the drawing board. Now, the management of massive PE, if you're suspecting it but you don't want to wait for a CTPA, you need to make sure the ABC is stable. So you need to do your, what we've done on the AIM course. So oxygen therapy, high flow to over 94%, and fluid resuscitation, but cautiously, as you don't want to overload the taxed lungs. If you confirm the PE via CTPA, or if the patient continues to deteriorate after your clinical suspicion and becomes hemodynamically unstable with a right ventricular strain on echo, then you need to heparinize the patient. and you need to thrombolyze the patient. So alteplase is a tissue plasminogen activator, and plasminogen busts the clot. It breaks down fibrin. You need to make sure this is initiated less than 48 hours from onset of symptoms. And you can consider inotropic therapy. So positive inotropes increases the contractility of the heart. So if the heart's starting to fail because of this right ventricular strain, you can give adrenaline first line and dobutamine second line, which will keep the contractility and rate of the heart up. Now, for costochondritis, MSK, you're going to do a chest x-ray just to make sure that you're not missing anything particularly, nefarious. But the management is something simple. It's just NSAIDs and rest if it's MSK. MSK is usually a diagnosis of exclusion. Okay, it's not anything that we're worried about on MAP, therefore MSK. For Abdo, you're going to begin with a PPI trial, proton pump inhibitor trial. So you'll put them on omeprazole and you'll see what's what, basically. If they have any of these alarming symptoms, you're going to do an OGD, an esophageal gastroduodenoscopy. Okay? So you put in a scope in for the esophagus, the stomach, and the duodenum to have a look, basically, at the upper GI tract. If the patient is over the age of 59, they need an OGD, or if they have any family history of malignancy of the upper GI, any unexpected weight loss, dysphagia, odonophagia, vomitus, or blood, and this is excessive vomitus for a while, these are the alarm symptoms. Any of these, they need an OGD, not a PPI trial. So if it's a regularly healthy 65-year-old who presents with symptoms of pyrosis, worse on lying down, they can't enjoy their wine, and they've got a fatty diet, they need an OGD because of their age, even though they don't have anything else. Management of gourd pepticulture disease is a PPI anyway. You're going to give them omeprazole and lifestyle, so they need to monitor weight, head of bed elevation to make sure they're upright so they're not supine. But eliminating some of the fun stuff like chocolate, caffeine, alcohol, and spicy foods, unless they're known triggers, it's not particularly evidence-based according to BMJ best practice. So, we're getting there. ACS. So it's divided into three things: unstable angina, NSTEMI, and STEMI. Your unstable angina is ACS with an absence of biochemical evidence of ischemia. So the ECG is usually normal and the bloods are usually normal. So you might see ST depression or T-wave inversion, but usually nothing. You need to treat them with MONAC and lifestyle. So whenever a patient comes in with ischemic chest pain-like things, the crushing retrosternal, the pallor, nausea, vomiting, these different kinds of things, you initiate MONAC. This is the first-line treatment, even when you don't know which one it is. So that's morphine, oxygen, nitrates, aspirin, and then 3 Cs, cardiac monitoring, calcium channel blockers, and then consider thrombolysis. Okay. For the MI and STEMI, it's an acute ischemic event that causes myocardial necrosis. So there's actual necrosis. So there's things appearing on the results. Basically, ECG changes, but no bloods, or very few bloods. And then MI, that's a STEMI, you have biochemical evidence and you have the actual ECG changes. So in NSTEMI, it's ST depression, T-wave inversion, and you can sometimes get a transient ST elevation as well. You're going to start them on antiplatelet therapy and anticoag therapy. So your aspirin and clopidogrel, as well as your anticoags. Your STEMI approach is going to be seeing an ECG with ST elevation and your biomarkers. And these biomarkers are CKMB, creatine kinase, and this is for recurrent STEMIs. I'll explain what that means in a minute, but also troponin INT. So troponin INT will be raised up, and it stays up for a few weeks. But CKMB goes up and then comes down after a few hours to days. So if the patient is having recurrent STEMIs over the course of a week or so, the CKMB will jump up and down, but the troponin will only be raised once. So it might be slightly additive with each one, but not enough to be clinically useful. So you will use CKMB if you suspect mini recurrent STEMIs. Now, aortic dissection, you're going to do investigations, and that's going to be your chest x-ray, where you'll see a widened centre of the thorax on the chest x-ray as you're bleeding into that space. You'll do a transesophageal echo, and this will show tamponade and what's called a flap. And the other options you can do are a CT contrast or an MRI angio, where you'll also see the flap. Now, if we move to the aorta here, there's 3 layers, the tunica intima, media, and externa, or adventitia, and the blood runs in the lumen here. If there's a tear in the tunica intima, the blood will pool in subintimally, it's called, into the tunica media. This causes a flap that flaps away like this. You can see that on echo, CT, and MRI with contrast. The management of aortic dissection depends on the type. So there's type A, which is a rupture in the ascending aorta, and type B, according to the Stanford classification, which is a rupture in the descending aorta. The management of both is ALS, because you want to support hemodynamics and prevent the massive aorta from bleeding the patient to death. There's also a beta blockade, which will prevent further pulsatile forces. So you're going to give beta blockers and morphine if this doesn't work to decrease heart rate below 60, which sounds a bit terrifying in a patient whose aorta has exploded, but, it stops the patient exsanguinating. And for type B, for the descending aorta, this requires endovascular or open surgery to stent graft in place and close up this hole. Now, pneumonia, Nick's already mentioned the KERB 65 score. So this is a classification of the risk of patients with community-acquired pneumonia, not hospital-acquired pneumonia, because they're different causative organisms usually, and they have different prognosis therefore. So confusion, urea up, respirate up, blood pressure down, and age 65 over. Okay, so what they score is the risk. Okay, so whether they're in risk group 1, 2, or 3. And there's a big difference to mortality, and there's a big difference to outcomes. Okay, well, risk group 1, 1.5% 30-day mortality, low risk, they can have oral antibiotics at home. Risk 2, 1 in 10 will die within a month, so you should probably admit them and keep an eye on them with an outpatient follow-up. But 22% die at 30-day mortality if it's 3 to 5. So the patient needs to be admitted and management is severe. They might need to step up to critical care. Now, for community-acquired pneumonia, the most common organism is Streptococcus pneumoniae. And if the curve is 0 to 1, then they can have amoxicillin or erythro if they're allergic orally at home. If it's 1 to 2, add on clarithromycin and admit. If it's 3+, it's coamoxiclav and clarithromycin or erythro if allergic. Okay, so always erythro if allergic. These are your first-line drugs of choice. Obviously, follow trust guidelines. Now, for hospital-acquired pneumonia, it's Streptococcus pneumoniae again, but this changes if the patient's been there for longer than 2 days in hospital and then acquires it, in which case you need to cover for MRSA and Pseudomonas. Okay, so for non-severe HAP, healthcare-acquired or hospital-acquired pneumonia, the patient, they're not hypoxic, cyanose, they're not having difficulty of breathing and that kind of jazz. You're going to give them coamoxiclav. If it's severe, you're going to step it up to PIP and Tazo, and you're going to do this for a week in the following way. You're going to do IV for 2 days of PIP and Tazo. If they show chest x-ray and or clinical improvement, drop to oral for 5 of 7 days if they're improving, and that's your week. If not, keep them on IV until they improve, inform microbiology, and step it up. So when it's severe and the cultures come back and it's MRSA, you need to add on vancomycin. So PIP, Tazo, treat as severe as normal, 2 of 7 and then 5 of 7, and add on vanco. Again, follow trust guidelines. Now, pericarditis, flame inflammation of the pericardium here. You can do a chest x-ray, ECG, and echo. The chest x-ray will show a globular heart if there's an effusion present. So as this thickens, it will look globular in shape in the centre of the mediastinum. You can order an ECG and an echo. ECG might show ST elevation with PR depression, so it could be a STEMI mimic here. And the echo will look normal unless the pericarditis is starting to form an effusion within the pericardial cavity, in which case you'll see that on echo. And you might see it on chest x-ray as well. You're going to do nothing, usually, unless the inflammation is quite bad, in which case you can give them analgesia and NSAIDs to limit the inflammation. If the pericarditis is causing a tamponade, if it's constricting and preventing cardiac output, decreasing preload, raising JVP and the like, so Bextriad is starting to develop, pericardiocentesis to draw the fluid out. And you'll see the state of that on echo. Now, getting to the end now. So pneumothorax, tension and primary spontaneous. So the first line investigation is always a chest x-ray. Management is immediate needle decompression. That's in the second intercostal space, mid-clavicular line of the side affected ipsilaterally. That's if it's a tension, right? You need to move in there before you do a chest x-ray. And then oxygen therapy and chest drain is given later. Oxygen therapy from the beginning, because oxygen therapy can help expand a collapsed lung, particularly for primary. And then once you've done the needle decompression, it's been a success, you're going to put in a chest drain for definitive management of this patient and then admit them. So that's a revised triangle of safety approach from phase 1. If it's a primary spontaneous, it's just NSAIDs and codeine for analgesia. And that's if it's resolving, so starting to improve on its own, or just a minor collapse of like 10-15%. So pause here, have a little break, and then we'll come back. We've got some quick stems here. All of these are answerable from the actual lecture that we've just had. So given the best match differential of Boris here, what are your first line investigations? So pause this and have a thought. Okay, so he's describing GORD. So you would normally do a PPI trial, but this patient's over 59, so they're in the alarm category, so an OGD is warranted. Just cheeky questions you would ask to differentiate this from a classic pneumonia presentation. So pneumonia is infective, so you need to ask about abnormal weight loss, appetite, fever, torrential night sweats. You need to ask for shortness of breath, myalgia, fevers, and the like. And then coughing, productive or dry. You need to ask about the quality of the chest pain sensation. So is it pleuritic? Is it pyrotic, as we said? Name 3 risk factors for the best match differential. So patients with GORD, smoking, alcohol, fatty, salty foods, family history, and the like. Natalie's 30. She's irritated by a stabbing pain in her chest that hurts more when she pushes down on it. It's right here, she says. So it's localized. Now, if we say given the best match differential, what are your first line investigations? Well, this is pointing towards MSK, given that it's a replicable pain. She's young, she's got no history of anything else, and it's a stabbing sort of sensation. So given the best match differential, you're going to do a chest x-ray to rule out anything nefarious. The mechanism of medication is a COX inhibitor, a non-selective COX inhibitor, because you're going to give NSAIDs, you're going to give ibuprofen first line. You could also give codeine if necessary. Natalie returns 2 weeks later stating your pill didn't help. What would you do next? So you would do an intra-articular glucose injection. Now, Cleveland is 70, retired butcher, collapsed whilst gardening, and is brought into ED via ambulance. So I'm concerned, given his demography, his age, and his presentation, that he has ACS. And basically, you need to go through MAP, but it's ACS, basically, until proven otherwise. Could be a PE, could be an aortic dissection, so the time-critical stuff you need to go through first. Patient has a notable history of hypertension, so that's screaming ACS or a dissection. What is the first-line drug this patient would have been prescribed? So the patient is he's black, therefore that means that he's most likely to be on a calcium channel blocker. So it could have been nifedipine, amlodipine, and the like. Discuss the rationale of the first-line investigations ordered in this acute case. So this patient needs, first and foremost, an ECG, full vitals, well that's an examination, isn't it? An ECG for the ACS thing, and cardiac enzymes. So your CKMB or your CHOP-IT, and usually CHOP-IT and ECG is what you need. So demonstrate how you'll immediately manage this patient, so it's MONAC. Morphine, oxygen, aspirin, nitrates, calcium channel blockers, cardiac monitoring, and consider thrombolysis. And finally, Beth, 32-year-old, second pregnancy, chest pain on inhalation that's stabbing and is becoming increasingly breathless. She's tachycardic. Okay, so pause the video here, have a think. Now, how will you risk assess this patient to enable the next stage of management? So this patient's going to get a D-dimer because of the clinical findings say that she might have it. So D-dimer on a Wells score, if it's over 4 and the D-dimer is positive, you're going to treat. If it's only one of those two, so Wells positive or D-dimer positive, so one of those two, she needs to have an ultrasound of her lower limb and CTPA. She won't be able to have a CTPA because she's pregnant, so she needs to go for a VQ scan, a ventilation perfusion scan. And then if she's negative for both D-dimer and has a low Wells score of 4 or below, then you need to go back to the differential drawing board. Utility of adrenaline administration in this patient. So there's a bit of a debate in the lecture as to whether or not you would administer adrenaline to a pregnant patient, but in general pulmonary embolism,